So, should we get started? We're okay. All right, I think we can get started for what I think you're going to find a very exciting workshop or panel. Today we have three great speakers, and they're covering some important topics. I'm the moderator, and I'm Barry Kramer, and I'm a member of the Lisa Schwartz Foundation for Truth in Medicine. I don't have any relevant conflicts of interest. However, along with the rest of the Scientific Planning Committee, I did receive travel expenses from the sponsor of the conference, the University of Oxford. And I have an unrelated grant from a nonprofit foundation through the Lisa Schwartz Foundation for Truth in Medicine for establishing a medicine in the media curriculum for training journalists in accurate reporting of medical stories. And I have received an honoraria for giving a 2-day course to journalists at Stat Publication in reporting. But other than that, I have no conflicts and none are relevant to this session at all, or this meeting. Here are the learning objectives. Attendees will be able to identify elements of clinical specialty training and practice that increase the incidence of overdiagnosis, list examples of such overdiagnosis coming from specialists and subspecialists, and to describe emerging techniques to identify overdiagnosis, such as cancer at the individual level, and to mitigate its effects. We have three speakers. The format will be each of the three speakers will talk for 20 minutes, and they'll go in succession. I'll introduce them individually, and for the remainder of the time, we will have open Q&A periods, some from the audience, and some from Dr. Jenna Smith, who is sitting in the front row and monitoring the chat so she can articulate some of the questions. And this is a list of the panelists. Dr. Correa is a full professor in cardiology and director of the Center for Evidence-Based Medicine at the Medical and Public Health School of Bahia, Brazil, and he's also the Dean for Medical Thinking at the Medical and Public Health School, and he serves as co-director of Choosing Wisely Brazil. He's our first speaker.
Thank you, Dr. Kramer. It's a pleasure to be here. Thank you, Eddie, for inviting me. It's been fun to talk to so many interesting people and discuss in such a style of meeting that is about medical thinking. That's what I like, and what I have dedicated part of my career in academics. I should say where I come from. I come directly from the U.S. I live in the U.S. now, but actually I'm showing my experience and my research basically from Brazil. And Brazil is a very interesting health system. It's the combination of a public health universal system that tries to be rational with a private system that 30% of the population is able to pay, that tries to promote overuse. And this private system is able to influence more of the mindsets of the country than the public universal system. So we have problems of overuse. I think it's even in some circumstances worse than the US. And so we have dedicated part of our evidence-based medicine approach and teaching and research into this issue. But I'm supposed to talk about what I am as a clinician. I am a cardiologist, and I love cardiology. And one of the things I love is I am able to tease my colleagues about overuse. And some of them like, actually. And so I'll start with this example. Imagine this patient comes to our office in the beginning of December, and this is a very special patient, VIP, and he wants to make sure he's okay for the Christmas night. Christmas night's a lot of effort, and he's maybe concerned if he's going to have a heart attack or something. So this situation is a situation that leads very commonly to screening of coronary artery disease in asymptomatic patients like this one. Nobody ever heard that Santa Claus has angina or heart failure or things like this. So he is asymptomatic. He's functionally normal, actually. But normally, when he comes to a physician's office with this concern, we will do a test, a screening coronary artery disease that is the leading cause of death in the elderly population. So it happens a lot in our environment. This is one of our studies. And we evaluated in one of the cities in my states, the prevalence of inappropriate stress tests, treadmill exercise stress tests, and we found that 78% of the tests done in that environment was inappropriate, mostly asymptomatic people. There was a 60% higher rate in the private, if it was the private system in comparison to the public system, but even the public system had 50% of inappropriate tests. So what's the problem here? The question that comes to this talk is it a cardiologist problem? If Santa Claus went to a cardiologist's office, would there be more screening than a non-cardiologist? Actually, it's a question about causation, a question about risk factor. So cardiologists are a risk factor to overuse cardiologist tests. That's the question. And I have to say, there's not much data about this. I searched the PubMed about overdiagnosis in the title, and there is 1,000. And when I tried to combine overdiagnosis and causes, even using causes in the abstract, only 48 studies evaluate causation of overdiagnosis in an epidemiological approach. And I have to say, none of these were really answered the question. There is one study that evaluated this situation, stress tests by the cardiologists, and compared different specialties. Actually, it didn't show cardiologists were the first one to order stress tests. I'm using stress tests as an example. I could be talking about coronary CT or SPECT or other things like this. So I don't know. That's the answer. I don't know if the cardiologist is a problem, although it seems it is the problem. But if we adjust for the situation the cardiologist is, because sometimes the patients look for the cardiologist because of heart concern, if we adjust for that, would the cardiologist order more tests than the non-cardiologist? The answer is, I don't know. But there is interesting data about this. One of the data I like is this one. It is a natural experiment, actually. And they compare, as you can see, outcomes of cardiac patients during the American College of Cardiology meeting. It's nationwide in the United States, but during the American College of Cardiology meeting, that week compared with control weeks. And so it's an instrumental variable, actually, the meeting that would lead to lower number of cardiologists in the hospitals. So results. For situations of low predicted mortality, it's similar in the week of the meeting and not the weekend of the meeting. In the situations of myocardial infarction, also the mortality was similar, and I remind you that ST segment elevation myocardial infarction is a situation that everybody has to do. It's a do situation, and do fast. But the interesting finding here is in heart failure and cardiac arrest of general causes. As you can see, during the week of the meeting, the mortality was lower of heart failure and cardiac arrest. So it's provocative. It's more of a reflection based on this. It doesn't prove causality, but it's very interesting data. So there may be a possibility that the cardiologists are the problem. So How about the guidelines? Is the problem our guidelines? I'm one of the most critical person about cardiology guidelines. They are not so good, in my opinion. But my answer is no, it's not the problem of the guidelines. The guidelines don't say, in most of the situations, there are exceptions, but I don't see much of recommendations of overuse of tests. For example, in the screening of coronary disease, in the primary prevention, there is no recommendation in cardiology for test the asymptomatic patient. Actually, the recommendation is to evaluate risk factors, to evaluate risk of event and not diagnosis. So I don't think it's a knowledge problem. If we ask cardiologists, we did Choosing Wisely in cardiology in Brazil some years ago, cardiologists like the idea. If you do the survey, it's very good. It seems like very good. So it's not a knowledge problem. It's not a guideline problem, in my opinion. I think it's a behavioral problem. It's not a recommendation. It's a behavior. And why do we behave like this? It's a biological problem, actually. We are biological wired to control situations, to look for solutions. And sometimes solutions is not evidence-based. We are biological wired to action. So it's a biological problem. So my first idea here is it's a difficult problem to tackle. And we need a very complex approach to make it behavioral change. What happens with specialists? We are the end of the line. So we have a tendency to promote certainty to our patient. The other generalists sent to us, we are the last resource. So we have this search for a platonic certainty. There's no certainty in medicine. Medicine is the science of uncertainty. But we look for this platonic certainty, especially as specialists. We are not counterfactualists. We never think about, what if I didn't do this test? Counterfactual. We are consequentialists. We want to do something to improve, to promote a good consequence. And this consequentialist view of the physician promotes this sense of this look, the search for controlling and guaranteeing Santa Claus, your tests are okay, you're not going to have a myocardial infarction in December. Also, we have action bias. We have to do something. It's part of our nature as a physician. It's difficult to say, don't do. We learn how to do. So it's only natural. It's not a problem of knowledge. But I think the specialist has a good side, confidence. We have knowledge. Because it's difficult not to do. So you need confidence in not doing. Sometimes as generalists don't have this confidence. And I'll show some data of our group regarding to confidence. We evaluate uncertainty aversion, and we show that uncertainty aversion predisposes to overuse. There is this scale of uncertainty and uncertainty and non-confidence, and we connect, you see in this axis here, we have anxiety due to uncertainty, and here the probability of inappropriate PCI. And we show this. The more uncertainty I have regarding that clinical situation, the more I do inappropriately. So then we have experience here. Experience. And here, confidence. And that's the thing. In the beginning, I'm not experienced. I have a lot of confidence. While you're learning, you diminish your confidence. This is real data, okay? And then you start, as a specialist, gaining some confidence. Maybe this confidence is necessary to do less. What this graph reminds you? What is this effect? You know this effect. It's the Dunning-Kruger effect. So we can use this moment of the Dunning-Kruger effect based on our experience, on our knowledge, on our confidence, to try to tackle these limitations of our biological mind, that is, to do a lot. So I think this is a good side of the specialist. So I think it should be seen as a public health problem, not a knowledge problem, not a recommendation problem. And we should use behavioral change techniques in public health, use it in public health. What's the public health achievement, the most important public health achievement of the 20th century? What's that? It is smoking, right? It's not passing the real graph. It is smoking decrease. So we were able to do in behavioral change techniques, approach to make important change in smoking in several populations. So it's possible. It's very difficult to reduce this. It's possible. But we only think about behavioral change towards our patients. Patients have to behave better. But how about the physician? We have to do the same approach with the physician. So behavioral change approach, it's a combination of psychological approach, ecological approach, opportunity cost, efficiency, all the things I'm going to speak of, in these last minutes here, suggesting some stuff. This is the one of the models. It's called belief model. And the idea of this psychological approach, interpersonal approach, is about motivation, not knowledge, motivation. I'm motivated to do something. So in motivation depends on perceived threat, perceived benefits, perceived barriers, and self-efficacy. So we have to think about these components to motivate the physician to do the right thing. The thing is, this threat and these benefits is of our patient. But sometimes we don't put ourselves in the place of the patient. So we have to discuss and identify situations that the physician see benefits for herself in doing less, or see threats for herself in doing less. And we have to nudge and diminish the barriers and work with self-efficacy, which means I believe I can change. Also, the social ecological model is very important. It's not only individual approach, it's relationship approach. I should change how the community thinks, so I'm approved by my peers in doing this or that. And also policy, societal approach. Policy, how the health system works and incentives and things like this. So it should be really a multi-complex approach. And about opportunity cost, this is a study of us. We thought the anesthesiology order a lot of coronary screening before surgery. That was our hypothesis. And we tested this also in the two systems. It was like 800 surgeries in 1 year. And so my hypothesis was that it would be high, inappropriate ordering of screening coronary disease before surgery, non-cardiac surgery, and this is our result, 2%. What happens here? If the anesthesiologists do their diagnosis, there won't be the surgery. It's opportunity cost. So we have to work this way. And if you have Santa Claus looking for you in December, and you test, and I look at the internet, he has 500 years old. For sure he has coronary disease. If we test, we're going to find, and we're going to lose the opportunity of Christmas. There's a big opportunity cost, and so that's the approach we need to talk to physicians and trying to change culture. Another thing, I think we have to replace overuse by efficient use. It's not only about doing less. We should be worried with underuse also. And if we talk about efficient use, I think the physician will be more motivated. You don't do this, but you do this. That is the important thing. Finally, confidence may lead to change. We need confidence to do less, and the confidence in terms of knowledge, is with the specialists. So I criticize my specialty a lot, but I came to the conclusion that maybe if we use the specialty in the right way, the solution may be led by cardiologists, and then the cardiologists may influence the other specialties. So William Osler approach, medicine is the science of uncertainty and the art of probability. We should abandon the Platonic certainty and embrace uncertainty in our decisions. I think that's the thing we should always remember when we have a patient in front of us. Thank you.
Outstanding talk. Our next speaker is Dr. Laura Esserman. And Laura is professor of surgery and radiology at the University of California, San Francisco, and director of the UCSF Breast Care Clinic. Her work in breast cancer spans the spectrum from basic science to public policy issues and the delivery of clinical care. And she's a thought leader in cancer screening and overdiagnosis, as well as innovative clinical trial design. This afternoon, she's going to describe some of her innovative designs that are already having a large impact on those areas. It's a pleasure to introduce Laura.
Thank you so much. All right, after that incredibly elegant talk, take all that into your brain, and I'm going to hang some details on it. Hopefully, not too many. So this is back and forth. Okay, great. All right. So I'm going to talk about overdiagnosis and overtreatment and what are the drivers and the moderators of that, and what can we do? Because I am a person of action. I want to make a difference. I accept all the problems, and I don't accept that there aren't solutions, and not doing anything isn't the solution because disease exists and it's serious. So how do we do that? So the punchline is that risk assessment, early endpoints, continual monitoring, and continuous improvement are the solution. So now I'll try and show you why that's so. So Barry already showed you these, so I don't have to go into it, but these are the objectives for today. And I'm going to talk about the first two, and then I'm going to show how we've used trial design to help figure out at the individual level how we can make a difference, because we can. Now I want to point this out. This actually was a framework that I think came out of this meeting. And we've been working on it for I don't know, it seems like a decade. But anyway, it finally got published. Fantastic. And this was that health screening needs independent, regular reevaluation. And I'm going to give you case in point with screening mammography for why that is so. You will love this, and I will cite this when I write this up in the next month. Okay. So first, in 2014, we did an aggregate cost of mammography screening in the United States, and we compared the current practice and all the different guidelines that people use. And here, what we showed was that this is the biennial screening. This was the U.S. Preventive Task Force guidelines, and these are the components of mammography cost and recalls and biopsies. And this was the actual cost with about 62% of the population screened. And this is what annual screening would cost if we got 85% of the population screened, which is what they do in the Netherlands and the UK and anyone who has real screening programs that aren't opportunistic. And I want to just point out to you that that is somewhere between 8 to 10 billion. That's with a B. And I want to point out that the cost of mammography was $135 at that time, 2014, that we said that was the Medicare rate. Okay. I'm sure you know where I'm going. Okay, so what's happened since 2014? Well, there's been the introduction of 3D mammography. Well, how much has it changed? There's a big screening, there's a big trial, the TMIS trial, looking at it to see whether it really is doing what it says. It's proposed as more sensitive for dense breast tissue with lower recall rate. There have been introduction of laws to notify women that they have dense breast tissue. By Red C, it's A, B, C, D. C and D actually make up almost half the population. So it's not very discriminating, I would say. There have been introduction of laws to mandate coverage of ultrasound screening in the setting of dense breast tissue, or telling people that they have dense breast tissue. And there's been a number of screening trials. TMIS, looking at 3D versus 2D. Wisdom, this is the trial I'm running, the personalized screening versus annual screening. and the MyPEBS, which is our sister trial in Europe, looking at personalized screening versus what the standard is in Europe. Again, we all have different standards, even though we look at the same data. So again, so what about 3D mammography in the US? So 3D mammography, or breast digital tomosynthesis, at about 2016, the US Prevention Services Task Force said there's insufficient data to recommend it routinely. That's in 2016, so it has to be tested. No one mandated coverage in the setting of a trial, which they could have, and that would have made the TMIS trial enroll like that, but they didn't, so that's just where we are. And so we went to Optum, which is one of the largest claims databases in the country. This is real-world data, and this is Optum, comes from United Healthcare. Okay, just setting the picture. 2D mammography is pictures taken front and the side of the breast, creates single images of the breasts. 3D imaging is multiple pictures of the breast from various angles and shows layers of breast tissue. It's more complex to look at, it takes more time, so people, therefore think that they should be reimbursed more, which initially they weren't, but you'll see, actually, they are. Here's the real-world data. So in 2016, the uptake was 23%. In 2020, before the pandemic started, it was 82%. Okay, let's see what happened in recalls. So this is for diagnostic workup. It went from 30% to 77%. I would argue the cat is out of the bag here. And so what about the recall rates? Are they lower? Actually, not really. They're not lower. What about the median cost of screening? Medicare does a better job of trying to control the costs. But for 3D to 2D, you can see that the price of mammography is actually higher in the commercial. So we used Medicare rates when we did our study. You can see that's why we had that $135. But here's the commercial rate, which, by the way, applies to about 75% of the population getting screened in the US. You can see I'm just pointing this out, close to $350. And here's the recall rates, less difference in recall in the Medicare and a big difference in the commercial population. Now, what about ultrasound? Are people doing screening ultrasounds? Well, they are. Here's the Medicare data on the left. So this is the recall rate. 25% with ultrasound in the Medicare population, and about, and with ultrasound in the commercial population, it's as high as 30%. That is just huge. Anybody who knows anything about it, that's really different. So is there a difference in detection? A little bit, but I want to point out to you these numbers. This is 1% versus 1.4%. It's a very small difference. And do we know what that is? This includes DCIS and invasive cancer. I can't give you any more data. This is seriously hot off the press, and by the way, we haven't published it yet. So anyway, I can't distribute it till we get it through everyone's approval sets, but I wanted to get this done to be able to show you at this meeting. So are these consequential? How much is incidental DCIS? So we're going to look at that. I wanted to show you something else, because we couldn't figure out why the rates were so high, the recall rates. In the US, they should be 10%. But if you look at 3 places that look at all the people who are doing screening ultrasound, the recall rates are 30%. So we looked then to see in New York, New Jersey, and Connecticut, that is where all of it is. It's all sitting there. And so we asked ourselves, what's going on? And here's the impact of the legislation in these 3 states. So New York says you have to cover digital tomosynthesis and breast ultrasound or MRI in the setting of dense breast tissue. In New Jersey, you have to cover without cost sharing digital tomosynthesis. And it requires insurers to cover breast follow-up evaluations such as ultrasound. Connecticut, the same. And I think that explains a lot. There are lots of these laws. I actually was unable to get it stopped in California, but I did get the requirement to cover these other tests out of the bill. That was the best I could do. But I would say if ever there was a case for reevaluation of screening, it is now. So I would say that 3D mammography has largely replaced 2D mammography without real-world evidence of improved cancer detection rates. The legislation impacts behavior. The recall rates are not lower as we had hoped, but we have a trial that will hopefully give us those answers before 2030. We should really push them to have an early answer wherever their data is. The use of ultrasound, those of us who know the field would say that it's a terrible screening test. There's so much false positive. And to see this happen it's just bad. It's bad for women, right? So 3D mammography has increased the cost of screening. We're looking at our microsimulation models, and I'm sure this is going to be somewhere in the $15 to $20 billion range. We'll have that next week. And also try to find out, well, what kinds of cancers are we finding and how much of this is DCIS and in what age. And I will tell you that the screening ultrasound rates for women who are under the age of 50 are astronomical. And that is why it's worth thinking about who needs screening in their 40s. And I just want to acknowledge the huge team at Optum at UCSF and at the Karolinska Institute with Martin Eklund and Andreas Carlson, who I've been working with. I'm not going to have too much time to go into this, but there's another issue here that if you really do have high risk, the right test is probably some kind of contrast imaging, contrast mammo or contrast MR. And it definitely increases the sensitivity but lowers the specificity. And it's not all high-risk cancers. So again, I think we need to do a better job of understanding who's at risk. So why does specialty training increase overdiagnosis and overutilization? I think because we're very willing to think new technology is going to be the answer without evidence of how it impacts diagnosis and the type of cancer recall. The people who are in that specialty, it's not their job to know any of that. They're just that first part. That's my job when they come to me, and that they're just disconnected from the biology and the treatment for radiologies. And I think that's one of the reasons why we have trouble. I think having the latest treatments, adding more fits the mental model in the US especially. All the incentives line up. You want to keep up with the Joneses. If the hospital across the street from you has 3D, if you don't have 3D, then people won't come to you, so you get donors and that's part of it. And I think DCIS surgeons and radiation oncologists are apparently not motivated to reduce their services and take the time required to develop and test non-operative management. People come from all over the world for me to do nothing. Most people are not going to do that because they don't get paid to do that. So that's a problem. But I'm going to show you how we're going to change all that. But I think people are afraid of being blamed for an event. If anything happens, there's just bad news. You can be blamed for it. And you don't get rewarded for doing nothing, except by the people you're seeing who are so happy. And there's a constant undervaluing of the impact of interventions. But I would say that trials can be designed to decrease overdiagnosis and overtreatment. You can do more for the people at higher risk, less for the people with lower risk, and de-escalate when treatments are effective and escalate when they are not. We can do it, but we have to have the tools and the framework to know the difference. I want to commend Barry Kramer for when he was the division director at the NCI. He actually created a whole program and real interest in helping people develop scientific careers to do that. I just hope we can withstand his having left. Anyway, we're going to keep on keeping on. So what is the solution and what is the mitigation? I'm going to try and go quickly to show you 3 examples. Biologically targeted trials, changing the paradigm for who we treat and how, make sure you know the impact of what you are doing and who is benefiting, and reorder treatments so that you learn. Don't just do stuff. That's how we got where we are. And it's not, the answer isn't not doing stuff either, as was just pointed out so elegantly. We have to be smarter. So we have to build the opportunity to improve into everything we do, and it requires measuring outcomes as a part of care. So that's that, whether it's screening, diagnosis, treatment, or survivorship, you want to have personalized intervention. When risk is higher, or response is better, or a response is lower, you want to escalate. And if the risk is lower or your response is great, then you can de-escalate. And I'm going to show you how we can do that. And I would also say there's a big fear of straying from the guidelines. And a lot of our guidelines are if A is better than B, we do A. but it's not thinking about, well, for whom is A better? And how much is it better? For a 3% benefit, are we going to treat everybody better? That's like radiating everybody with DCIS when probably 10% of people need radiation. And there's just no emphasis on the negative consequences of overdiagnosis. And a big shout out to Alex Barat, who has actually just published this paper on interviewing people about overdiagnosis and their experience and their anger at finding out about it after the fact instead of before. So, all right, so I'm going to quickly show you a little bit of what we're doing in iSpy. I'm going to show you Recast, our DCIS trial, and Shelley's going to talk more about that tomorrow, so I'm not going to go into much detail, and very quickly what we're doing in Wisdom. So iSpy 2, very quickly, is a focus on women with high-risk stage 2-3 breast cancer. And what we did was instead of operating on people first, as a surgeon I can say, people at risk to die of their disease are not helped with surgery. They are helped if you know what works, then you can clean up and take the tumor out. Or not, if it's already gone. And it actually is very cost effective if you do it that way, because you know where it's working, where it's not. And we've had this as an elegant adaptive platform where we've tested 27 agents over the last 10 years. These are all the agents that we've tested. We just keep learning and going. And over the course of that, we've introduced immuno-oncology agents, hopefully for the right people. This is what complete response looks like by MR. We've used MR as an imaging endpoint. And we've shown that if you achieve the tumor going away, that's the blue line, that's a Kaplan-Meier plot. These are people who are at serious risk to die of their disease, right? So this is a 45% survival. That's bad, but 92% is pretty good. So that's what we want to achieve. We want to try and get everybody to that better endpoint. And so what we did in this trial is we said, okay, we're going to start, and that drug, the success of Keytruda came from this trial because we took the risk and said, let's start it up front. And we showed that it was one of the agents that made a big difference, and we figured out for whom it made a big difference. And then, only then would they get anthracycline, which people hate. The patients call it Red Death. But we found that once you have a complete response, you can go to the OR and skip this. Because once you have a complete response, doing more does not help you. This is a fantastic opportunity for us to move things forward. So what we also did was we developed, because it was a biomarker-rich trial, we figured out how to reorganize all of these different biomarkers and figured out what the response predictive subtypes are, which is really important because it allows us to tell who's got what kind of cancer. And what we did is now we've got the new therapies, these targeted antibody drugs that might allow you to skip all that standard chemotherapy. If you get a complete response, you can go to the OR. And we start to know who's at risk for these kinds of cancers because it's all scientifically based. That's going to drive into screening and prevention to help us figure out who's at risk. And so you can sequentially escalate therapy or sequentially de-escalate therapy as people do better. Recast DCIS is reevaluating conditions for active surveillance as treatment. This is part of our pilot. Only 3% of patients opt out of standard surgical care, but we have figured out by giving the hormone therapy up front, since 90% of people have hormone-positive DCIS, that 70% of people, 60 to 70% of people probably don't need surgery at all. And you can figure out who's got a focal mass and who needs to go to the OR, and who's good for prevention, or which prevention things don't work, so we can come up with better things or things that are more tolerable. And what we figured out is that MRI, the same thing that we use for high-risk screening, can be used to tell us who needs what therapy. This is your classic DCIS, calcifications everywhere. This was a primary care physician. I said, look, let's just get an MRI and see what you have, right? So our initial MRI shows everything lighting up. I said, look, just take tamoxifen for 3 months, and if it all goes away, we'll find out what you've got left. Nothing. She's now 2 years out. So this is the point. Don't be in a rush. Find out and learn. So now we're doing this as a multi-site test with a multi-center test where we're trying a SERD, which is much better tolerated. So this gives us a chance to say, what are the drugs we can do that will help with prevention and help people stay on them because they're more tolerable? And this is the opportunity, so we'll test that. And those who need to go to surgery will, and those who don't, fine. We'll figure that out. And we know it's safe to do because we're doing this exact thing for people with high risk, clinical high risk, molecularly low risk, hormone positive cancers. Okay, so we know that breast cancer is serious. 42,000 people die, and African American women die at the highest rates. And that's despite screening. And all those people in the I-SPY trial, 85% of them don't come through screening because they have interval cancers. That's biology. And so we have to do better at figuring out who's got what kind of cancer. And the other side of the story is that we have 276,000 cases. In there is buried the people who have disease that's not going to kill them. It's a lot, right? So we have to figure out who that is. And it's like allergy. You don't want to give Zyrtec to the person who's going to have an asthma reaction. If you have seasonal allergy, you take a Zyrtec. If you have, asthma with ragweed, you take an inhaler. And if you're allergic to bee stings, you would take epinephrine. We don't tell women to go out and get a size 8 gene. Why do we screen as if everyone's at risk for the same cancer? Which I hope I've shown you that you're not. Here are the different. This is the fast-growing tumor. We're not likely to fix that with periodic screening. These are the ones we want to find early, and these are the ones we want to ignore. And the thing about it is, better. Not more for the people who need it, less for the people who do not. And I would venture to say that we do know. I have personally worked on and developed tools that allow us to say who's got ultra-low risk at the time of diagnosis so they can do less. So this is recent paper saying, oh, thank God it's not 30%, it's 15%. How great is that? That's 70,000 people a year who are overtreated. We can do better than that. And, are we going to tell both of these women to screen? Well, it depends. If you're an internist, you'd say both of you come at 50. If you're a radiologist, you'd say they both come. But in fact, that's not the right answer for either of them. Veronica's a mutation carrier whose mother died at 36. She needs to be screened in her 30s. And Kim, doesn't have any risk or polygenic risk. So she could start in her 50s. So what we need is to make screening better. Integrate risk assessment, screening and prevention, and a modern era trial. That's what the Wisdom study is. We're trying to test this in women 40 to 75 without a history of breast cancer. We have 45,000 women on the trial now. We have a group that's randomized, and if people don't want to be randomized, they can choose. They can choose their arm because there's bias in the people who don't want to go on a trial. And this way we can try and bring everybody on. And we're just trying to find out if it's as safe, whether it's less morbid, whether it improves prevention, whether it's more acceptable, and whether there's overall healthcare value. And importantly, we're going to move to Wisdom 2.0. Because what if we knew who is at risk for hormone-sensitive tumor? We could think about the right prevention medication. What if we knew they were at risk for these immune-driven cancers? There are things that we can think of for that. But we have to get ourselves onto that path. And this is our future. So this is where we're actually doing this with a whole stakeholder group. You'll be happy to know. And we're going to all vote. We're going to do all the simulation models ahead, and we're going to vote on what that 2.0 strategy should be. I hope all the insurers will say they want to do coverage with evidence development and let us do it as we go. I don't think that'll work. I'll still struggle over it. But there are plenty of resources in the system to do more for the 2 or 3% of people at very high risk. Do you know, one last fact, we are doing population-based screening. Of the 2% of people who have mutations, 2/3 of them do not have a first-degree family relative. So that is a bad screen. And we're not helping them, and we've known about this test for 20 years, and we have not put it to good use. So the tyranny of the status quo can be fierce. I would say this was Dan Coban's article last year about the Wisdom trial is based on faulty reasoning and has major design and execution problems. I don't care if he says that, but I cannot believe that the editors put that out. I made them publish this, of course, where we did our rebuttal. And I, of course, had to finish by quoting Elias Zerhouni, who himself is a radiologist, was the NIH director. And I say that the greatest risk in science is to stop taking risks. And for discovery and innovation to thrive, we have to have a culture that prizes habits of thinking outside the box and posing novel questions. And while caution and safety are important, so too are courage and imagination. And if we're ever going to get to a higher level, we have to be willing to let go of the rung to which we are clinging. And that was my response to Dan Copan's. Okay.
That was another remarkable talk. And the next talk is going to be a virtual presentation from Louise Kazda. Louise is a PhD candidate and research assistant at the School of Public Health, University of Sydney, and with the Australian Wiser Healthcare Research Collaboration. Her thesis investigates trends and outcomes of attention deficit hyperactivity disorder diagnoses, ADHD, in children and adolescents. She holds a master's degree in public health and, as I mentioned, is a PhD candidate. You have the recording.
Hello everyone, and thank you for inviting me to give this talk about diagnosing ADHD. My name's Louise, and I'm a final year PhD student at the University of Sydney. I would like to use this time to share some of the highlights from my research over the past 3 years with you. As it happens, I'm an epidemiologist in training, not a clinician, and this talk will be centered around results from my PhD. So I'm suggesting that epidemiologists are also specialists with a role to play in mitigating overdiagnosis. Before I start, I would like to point out that my research is focused on ADHD in children and adolescents, so I'm not going to be talking about ADHD diagnosis in adults today. Also, I would like to note that I received a PhD scholarship from the Australian National Health and Medical Research Council. Apart from that, I have no conflict of interest to declare. Let's start at the beginning. What actually is ADHD? Attention deficit hyperactivity disorder, sometimes also called ADD, attention deficit disorder, or neurokinetic syndrome, is defined in the DSM-5 as a persistent pattern of inattention and/or hyperactivity impulsivity that interferes with functioning or development and negatively impacts on social and academic activities. So this is the definition that's currently used in most parts of the world when diagnosing ADHD. I have highlighted 3 important aspects here, namely that the behavior needs to be persistent and not transient. It needs to be interfering with functioning and have a negative impact on the child's daily activities. In this session, we've already heard about diagnosing and overdiagnosing cancer and heart disease. And I'm sure everyone here has a fairly good understanding of what overdiagnosis actually is. But just to recap, here's a definition of overdiagnosis in non-cancer conditions, such as ADHD. It's defined as where a person is clinically diagnosed with a condition, but the net effect of the diagnosis is unfavorable. So, because overdiagnosis in symptomatic non-cancer conditions is quite different to that in cancers, we adapted a framework that was published by Bell and colleagues in Annals of Internal Medicine in 2019 to guide our research. They developed 5 distinct questions that can help establish the potential for overdiagnosis in non-cancer conditions such as ADHD. Imagine an iceberg like this, where those children that receive a diagnosis are above the water threshold, and those that remain undiagnosed are below the waves. The first question then is, are these children below the threshold potentially diagnosable? i.e., is there a reservoir below the water that could be diagnosed if we lowered the threshold? Because if that is not the case, if there's no reservoir, overdiagnosis would be unlikely, right? There would be a clearly defined group to be diagnosed and it could not be expanded. Secondly, if there is this reservoir of diagnosable children, we need to know if these have been or are being converted into actual cases, i.e., is the group of children with a diagnosis actually increasing? The final three questions that are important to answer to establish if overdiagnosis is occurring are then all focused on this newly expanded group of cases. Are at least some of the additional cases subclinical? And what I mean by that is, are they below the clinically relevant threshold for diagnosis? If not, then it would appear that not overdiagnosis, but improved detection of previously underdiagnosed cases is happening. Are these cases being treated? And finally, most importantly, what is the balance of benefits and harms for these children? Clearly, if we think back to our definition of overdiagnosis, if all of these children benefit from a diagnosis and from any associated treatment, then they cannot, by definition, be overdiagnosed. So in the past 3 years, my team and I have been trying to answer these questions for ADHD by looking into what evidence was already out there and then by filling any gaps that we discovered. The first study we undertook was a large scoping review of what is already known on overdiagnosis of ADHD. This review was guided by exactly those 5 questions in the iceberg model I just showed you, and here are some of the results. Firstly, we found a huge potential for increased diagnosis of ADHD. Hyperactive, inattentive behaviors exist on a continuum, and to some degree can be observed in all children. So there's no natural, clearly defined group of cases with a strict cutoff, and at least theoretically, an endless supply of cases. As a result, we found evidence for a lot of diagnostic inaccuracy, the medicalization of behavioral problems, and the broadening of diagnostic criteria, which is also reflected in a very large variation of ADHD diagnosis rates in certain subpopulations. For example, by cultural background or by age relative to their peers. For instance, children who are the youngest in their class. Secondly, we found consistent evidence that ADHD diagnosis rates have increased substantially over the past 3 decades at least. Although there's a lot of data confirming this, we did not find any studies from our own region, Australia, on increases in diagnosis rates. So I'm giving this a lighter tick for now. For question 3, we found some evidence indicating that clinically significant hyperactive, inattentive behaviors in the wider population have remained unchanged over the past 30 years. Unsurprisingly, we found that the lowering of the diagnosis threshold for ADHD has widened the group of cases, and there was some evidence that overall impairment levels in the expanded group are declining. However, some studies suggested that the proportions of diagnosed children with mild, moderate, and severe symptoms are actually quite stable. Thus, even though there is good indication that some additional cases may be subclinical, we thought there was not enough evidence to completely answer this question. For question 4, our review found a clear and substantial increase in pharmacological treatment rates for ADHD since the 1970s. Any other treatment options were out of scope for this review. In this study, we looked at potential benefits and harms that can arise from the diagnosis itself and from pharmaceutical treatment. Briefly, an ADHD diagnosis can carry substantial benefits for children. For example, it can serve as a legitimate explanation for problems, thus reducing feelings of guilt, blame, anger, or failure. This can lead to increased sympathy, reassurance, and support for the child, their parents, and their teachers. On the other hand, a diagnosis may also carry harms, because it can serve as an excuse for problems, leading to significantly decreased perceptions of responsibility. There is a risk of creating a self-fulfilling prophecy, where a perceived inability to control or change behavior may result in disempowerment and increase of stigma, isolation, and feelings of failure. In terms of pharmacological treatment outcomes, it is quite clear that medication can lead to significant short-term reductions in hyperactive, inattentive behaviors, but also that it is often accompanied by mild to modest side effects that have the potential to be severe. Beyond that, we found quite a lack of high-quality long-term studies, so it was impossible for us to determine a definite harms-benefit balance. Overall, we concluded there was not enough evidence to determine which children may experience a net benefit from diagnosis and treatment and which may not. Back to our iceberg model. From the scoping review, we could clearly see that there is a large reservoir of potentially diagnosable cases and that treatment for ADHD has substantially increased. We also found solid evidence for increased diagnosis rates in many regions, but we did not find any studies from Australia specifically. Importantly, there were research gaps with regards to severity of cases and on the balance of benefits and harms. So to address the first gap, we aimed to find out who is actually being diagnosed. In the study, we had two aims: to explore if diagnosis rates in Australia had also increased, and importantly, if these potential increases were foremost occurring in children with clinically relevant hyperactive inattentive behaviors, or also in those with behaviors in the normal or borderline range. We were lucky to have access to data from the longitudinal study of Australian children, which comprises around 10,000 kids in two cohorts separated by 4 years. We used data from both cohorts where children were between 6 and 12 years old. To measure children's ADHD-related behaviors, we used the parent-reported hyperactive inattentive combined score from the Strengths and Difficulties questionnaire and categorized these scores into low-risk, borderline, and high-risk groups. Before I continue, I would like to note that these results are currently unpublished, and thus I would like to ask you not to share these, please. There was a significant difference in there was no significant difference in hyperactive inattentive behaviors between the two cohorts, neither for all children nor for just a subgroup of children diagnosed with ADHD. This graph only shows hyperactive inattentive scores for newly ADHD diagnosed children. As you can see, for 54% of these children, their parents rated their pre-diagnosis behavior below high risk, and for more than 1/4 of diagnosed children, their score placed them in the low risk group, suggesting their behaviors were actually within the normal range just before diagnosis. Additionally, we found the percentage of kids who had ever received a diagnosis increased by 1% within 4 years. The percentage of children who had ever been medicated for ADHD increased by 5%, and the average behaviors did not change. Together, this meant that the risk of receiving an ADHD diagnosis significantly increased for the children born 4 years later, and that was regardless of their level of hyperactive inattentive behaviors. So with this study, we were able to not only show that diagnosis rates have increased in Australian children, but also that a substantial proportion of children diagnosed display hyperactive inattentive behaviors within the normal range. The final piece to our iceberg puzzle then is the question of benefits and harms, which is exactly what we looked at for our next study. Just as a quick recap, why is this so important? If you remember from the beginning, the definition of overdiagnosis states that the net effect of the diagnosis must be unfavorable for overdiagnosis to occur. Because even if we diagnosed and treated every child, as long as every child actually benefited from this would not be a problem per se. To determine more holistically whether or not children and adolescents benefit from an ADHD diagnosis, we looked at the impact of diagnosis on quality of life outcomes in teenagers. Again, we used data from the longitudinal study of Australian children, this time over 8 years between the ages of 6 and 14. With this observational data, we emulated a target trial in which we used propensity scores to match children with diagnosis to similar children without a diagnosis. Importantly, we matched controls very closely on hyperactive inattentive behaviors, as well as on age, sex, and numerous demographics. We only used self-reported outcome measures to ensure that we captured the teen's own experience and not just their parents' perceptions. Here's a flow diagram of the study design to illustrate the approach we used. Unfortunately, the details of this are beyond the scope of this talk, but if you have any question on amylated target trials or are interested in the methodology, please feel free to reach out to me. Before I continue, I would like to note that again, these results are currently unpublished, and thus I would like to ask you not to share these. Here are some of our results from this analysis. We measured 9 quality of life related outcomes overall. The Child Health Utility 9D was our main outcome of interest, as it is a good indicator for overall quality of life in teens, combining 9 different domains into one overall score. As you can see, we found no effect of diagnosis on these or the other 3 outcomes shown here, with happiness and peer trust both approaching significance, indicating that those teens with a diagnosis were maybe marginally less happy and less trusting than those without a diagnosis. So in terms of quality of life as measured by the CHU 9D, overall health, happiness, or peer trust, similar teens with or without diagnosis reported very similar outcomes. However, in 5 other outcome measures, we did find differences between diagnosed and undiagnosed teens, and these effects were all negative for those with a diagnosis. ADHD diagnosis had a negative effect on teens' academic self-concept, their sense of school membership, self-efficacy, self-harm, and on negative social behaviors. It is worth pointing out here that girls generally scored significantly worse on nearly all our measures than boys did, regardless of their diagnosis status or their hyperactive inattentive behavior levels. Going back to our iceberg model one last time then, with this study, we were able to show that the harms associated with an ADHD diagnosis may indeed have a negative effect on the overall quality of life in adolescence, and that in at least some children, the harms may outweigh the benefits. Thus, we concluded that there certainly is evidence that ADHD is overdiagnosed in some children. In summary, we found that more and more children and adolescents are being diagnosed and treated for ADHD, globally and in Australia. We also found that it is not only children with clinically relevant hyperactive inattentive behaviors that are increasingly diagnosed, but also those with ambivalent or even very few hyperactive inattentive behaviors. Unfortunately, whilst we acknowledge that the benefits that many impacted individuals associate with an ADHD diagnosis, as well as the proven short-term benefits that can result from treatment, our latest data seems to indicate that an ADHD diagnosis does not necessarily improve quality of life for teenagers and can actually cause significant harm. Where does this leave us? Here are some suggestions of how specialists in the field can use their influence to minimize harms for children. Firstly, we urgently need large, well-designed long-term trials on the impact of an ADHD diagnosis on children's well-being. These should really be accompanied by qualitative research that directly involves impacted families. Secondly, pediatricians, psychiatrists, and psychologists need to be aware of the endless reservoir of potential cases that lies hidden beneath the water threshold and is increasingly being exposed. Diagnostic accuracy and thorough examination of all possibilities are important, and the increasing medicalization of behaviors should be considered in the diagnostic process. Following on, as with many other conditions, it is vital that clinicians consider the individual child's personal values and preferences, as well as their environment. For some children, non-medication treatment without a diagnosis might be enough to support them. For some, a more conservative step diagnosis or watch and wait approach might work well, whilst others may need urgent diagnosis and intervention on multiple levels. Finally, in an ideal world, real systemic change is needed to overcome inequities in education and beyond, so that children, regardless of their diagnosis status, their neurodiversity, gender, sexuality, ethnicity, location, or financial resources, receive the support and encouragement that they need to thrive without being harmed unnecessarily. Before I conclude, I would like to thank my wonderful team for all their support, also Wiser Healthcare for the funding, and of course, the longitudinal study of Australian children for all the data provided. Thank you very much for having me and listening to my talk.
So now it's time for the open question and answer discussion period, and maybe Louis and Laura can come to the microphones. And I don't think that Louise is able to be on the phone because, oh, there you are. Welcome. Thank you. So now.
Hi, everyone.
Hi. That was a great talk, and hopefully we'll have questions to direct to you as well. And Jenna, if you can give me a high sign if you see some questions there, maybe we'll start off and see if there are questions for discussion to any of the three speakers from the audience.
Thanks very much. I enjoyed. Oh, sorry.
Oh, go ahead. I'm sorry.
I enjoyed all the talks. I had a question for Dr. Esterman. One is, so I applaud your work on delineating risk. Absolute risk will obviously determine who's going to benefit the most. I have some questions about the earlier parts of your slides. One is, given that overdiagnosis can only be estimated through RCTs, should we be focusing on RCTs when there's new screening modalities that are being considered? And the second thing, I'm curious to know if you have any insights in terms of who the drivers were for the legislation that seemed to have caused dramatic increases in healthcare spending with very little improvements in health.
So I can answer some of that. So should we be thinking about, the problem with using claims data, which is what that is, there's a lot of it, so there are over 1 million claims. So you've got the law of large numbers, so that's helpful. But getting any detail is hard. So DCIS, which I didn't define, I'm sorry, is stage 0. So that's precancer. By itself, it's not going to kill you, right? But it does put you potentially at high risk. So what can you do about it? Some are not, some are. So is there a way, I think actually my belief is the way to look at overdiagnosis is to be able to biologically characterize the people who are diagnosed. And I think that there are increasingly tools that are going to be available that help us say, this is not cancer. We don't call this cancer, or come up with different names, right? That to me, I think Barry was hoping that we would do that. And I think that is possible. There's a lot of reluctance for it, but I think that's the way to do it. Is we need the thyroid people have done it. Pluto was declassified as a planet, so I think we can do it, and we just have to be pushing for it. But some of them are at risk. And the thing is that, we do want to do things. And, cancer is bad. So you can't just say, oh, no one needs it and cancer's not bad, because people see people dying of it. So, yes, it's there. So we have to do something better. And your second question was who was pushing the legislation? Advocates. Advocates were pushing the legislation. And so we've worked really hard to try and have a coterie of advocates well educated to try and counter that. And, there was a lot of publications about people, if you have dense breast tissue, you're high risk. Well, it got people all anxious. But then we defined high risk as like half the population. That's not helpful. And density alone isn't helpful. So that I think that that's why I think we have to really talk about risk. You talked about that as well, right? That yes, there are people at high risk, and we should try to do something about it. That's good. And do a better job of it. We just weren't prepared. We didn't have the right tools. And so I don't think that healthcare should be legislated. That's what led to the bone marrow, transplant business where we killed people. But, okay, or force coverage with evidence development. Do not allow these things to go forward without payment in our registry where we follow it. These are things that we somehow collectively have to make happen, just like the diagnosis of ADHD or whatever you decide in cardiology. Say we're going to do it, but do it in the setting of a registry, and no one gets paid for it unless it's part of a registry.
Dr. Correa, did you have a comment?
Yeah, the situation in cardiology, and I should explain better than I didn't have so much time there, is easier because there is no such a heterogeneity of treatment after the diagnosis. The way to prevent in a stable patient an event like a myocardial infarction or sudden death is the systemic treatment, like controlling hypertension, cholesterol, this type of thing. The diagnosis of a plaque has the mean to treat that plaque that is stenotic, and you can put a stent. But you put a stent in one plaque, and the patient still have 200 plaques that can have a myocardial infarction, and that's the reason why in several clinical trials, well-performed, try to prove that angioplasty in patients stable reduce myocardial infarction or death, and they are negative. So there's at least 4 good clinical trials because you're treating only 1 out of 200 plaques. And it's not the stenotic plaque that necessarily will cause the infarction.
Right.
So for us, it's easier the meaning of diagnosis and obstruction is to treat the obstruction. And we know that treatment of that obstruction doesn't improve prognosis. So if you want to improve, it's more of the systemic approach.
But you would see, this is what I say. I said, look, when I started practice, women were much more likely to die of heart disease than they were breast cancer. And that's no longer true because you guys have had a systematic way of assessing risk and intervening with things where you could measure that reduction in risk. And I say, and you believe that's made a difference, right? That's what we should be doing in cancer.
Yeah, because, cardiovascular prevention is more individual. So, and if you see, we had a reduction of like 60-something% of cardiovascular death over these decades, and not of cancer, because cancer is more difficult to identify that individual, what he or she needs to prevent. But it's much easier for us. We know we have these risk factors, and we
No, it's easier for you because you did it. You did the Framingham study, and you found the risk factors, and then you found the early endpoints and systematically went about trying to reduce them. We haven't done that. We could do it.
Well, what are the risk factors for cancer? I wonder if there's no such a risk factors, and things is more environmental. That's one of the possibilities. We have more individual risk factors that we can change, and maybe your situation, cancer in general, is more like environmental. So it's more difficult to predict. Like even the Framingham risk score is not a perfect, it's just a probabilistic prediction. But I think it's more stochastic in your situation. That's the challenge.
I'm not sure. So I think we can go on, but I would say that we can't. But just like cholesterol, you can see that background enhancement in the breast. You could make that go away. That's like cholesterol or blood pressure. There are things we can do.
Yeah.
We lack imagination, and we've lacked looking at the models where it got done.
So cardiologists are better.
Let me just ask if
100%.
Let me ask, Louise, do you have anything to add to the discussion? You want to break the tie?
I do think that ADHD is probably quite different because it is a symptomatic disease, right? It's probably a bit different to breast cancer or cardiovascular issues in that if you were looking for it, you could probably find some symptoms or behaviors in most children or adolescents. So it's quite a different disorder, I guess. And sometimes you have children that may be quite impaired who have less obvious symptoms than children who are less impaired and have more obvious behaviors. So it's not
necessarily easy to determine
But
either,
wouldn't,
I feel, in
but
ADHD.
wouldn't you say that it would maybe make sense to sort of think about not starting with medications, except in the severely impaired, and do behavioral interventions maybe, or simple things?
Yes,
There's an
so
opportunity
I
for that,
think
right?
I do feel, Laura, I was listening to your talk with interest, and you may know that Alex Barrett is my PhD supervisor, so I've, I guess, learned a lot from her about overdiagnosis in breast cancers. And I do feel there's a lot of similarities. And in your talk, you were talking about, personalized interventions and having certain steps along the way where you either escalate or de-escalate the care. And I do think that can also be and should be done in ADHD and other similar disorders, maybe. That, ADHD maybe not causing death like breast cancer as such, but I think it can be quite impairing and a real burden, not only on the child, but on the family. It can be a very serious impairment. So I think also the care needs to be quite individualized, but not all children may need a diagnosis. And it's certainly, from what we found, not beneficial for every child to be diagnosed as such. And then I guess the next step is then, do they get medicated or not? And I think what really needs to be asked here is, what do we expect of that diagnosis? If parents and children or teachers go to the doctors and say, well, I want my child medicated, then obviously you need a diagnosis. But what else does it do? There's behavioral therapies, other therapies that can maybe be offered without getting that label of that ADHD diagnosis. But yes, similar to maybe cancers and other disorders, it needs to be an individualized treatment there, or working with a family, working with a child to make sure that we're not harming the child along the way. And that should always be, and I'm sure that is at the forefront of all parents' minds, really. They want to help their child, It just doesn't seem, from what we found, that the diagnosis is necessarily the right fit for everyone. Like you said, not every woman should buy a size 8 jeans, and maybe not every child that has behavioral problems needs to be diagnosed and medicated for ADHD. And I do think the medication is probably a larger problem in the US than it is elsewhere in the world, like in Australia.
Thank you for that. We have time for maybe 2 more questions. I know there's at least one in the audience. And Jonathan?
I first of all comment from cardiology. I guess Mr. Claus, we're going to have to cancel Christmas because he's got about 450 years of uncontrolled diabetes on against him as well. Laura, I heard you talking in 2015 at this conference, and I actually directed a physician-patient to go and watch your keynote because it's lovely and it's online and recently. But so, I'm a male family doctor. I do not own a pair of breasts, and it is incredibly challenging to try and talk to patients about whether they should or should not screen. What would you say to the average risk 55-year-old in my practice? Should they screen or should they not? I think what you said last time was women should get to know their breasts, so if they decide not to screen, then they should come in if they notice something different. Yeah. But anyway, how do I do this?
Well, I think 2 things. One, if they're in the US, I would say join the wisdom study and help us make sure that tomorrow is better. But I will tell you, I'm going to be in Australia. I'm going to be in Melbourne the end of July, and I know that Bruce Mann is pushing to do something very similar in Australia. I think we need to make it better. We need to try and sort out who needs to be screened and who doesn't. And there are lots of tools. I don't have time to go into it, but there are lots of things that we can put to practice, right? There's polygenic risk. There are, just looking at some of the background factors. And, I think that you can do population screening. If you are a mutation or you have a high polygenic risk, okay, then you should be screened. If not, it's probably okay. And if you fit one of those risk factors, do something to bring your risk factors down, because there are things you can do. We need to be like the cardiologists. We need to aspire to better in that mode. Not like the interventional cardiologist putting a stent in everything. No, that's not what we want to do. But you know, the general cardiologists have done a lot of good. The PCSK9 inhibitors are like an example of escalation, which, by the way, may upregulate immune signaling and prevent,
Cancer?
believe it or not, yes, the high-risk immune type cancers, if you knew who was at risk for them, because it's about global benefit.
Yeah.
We have to use more imagination. So I think that encourage everyone to participate and say, like, there are questions we don't know. Be part of, you know, people say, well, why a study? Because if you don't study it and you don't know what you're doing, you can't improve it. It's still a problem. Breast cancer is a problem. A lot of people die of it. It's a bad disease. But doing it the way we're doing now is not good enough. And we can make it better, but we have to invest in these big systematic trials, just like the cardiologists did. And we have to make prevention and screening and integrated and risk assessment integrated. That's the ticket.
Yeah, let me make a comment.
We have a couple more minutes, and let me see first, and I'll reverse the order. First, see if Louise has any comment to add, and then Louis, and then we'll close out the session. Louise?
And there's one more question.
Yes, I think I sort of agree with Laura also in ADHD. I think we really need some large long-term trials. You know, that would be my sort of handing over to the clinicians with, I think, the data that we have now. We can see that some kids are being overdiagnosed and probably don't benefit from a diagnosis. But it would be really great to get some non-industry funded ADHD trials going, where we look at children with a diagnosis versus the children without a diagnosis, or maybe a step diagnosis approach. I think that's really, we really need to call for that, to really have hard evidence to see which children would benefit from it and which wouldn't.
All right, thank you. And Louis, you get the final word.
Yeah, I'll be fast.
Oh.
I like to make a comment about the symptomatic patient, making a comparison, Louis' talk. The example I choose to lead my lecture was the asymptomatic patient. But there is also overdiagnosis in the symptomatic patient. Let's take stable angina. What is the asymptomatic overdiagnosis in this situation? It's a symptom that doesn't affect the patient. So I don't need to improve that symptom. The patient's okay. It's just because I ask, do you have some chest pain? Yes, maybe I have. So that's what I call pseudo-symptomatic. So the real symptomatic patient is that one that you need to improve. So it may be the same with Louis' situation. You know, the real symptomatic patient that may benefit from the treatment for that condition is the one who really needs improvement, and not I'm going to, you know, ask questions or do such a thing. So stable angina is okay. It's stable too. Revascularization doesn't improve prognosis. The question is, do I need to improve the symptom? So I think in this situation, it's more like the clinical thinking. And I call the thinking the most important medical technology. And that's the technology we have to use in this symptomatic patients. I think.
Right. There was one last question, and we're sort of at the time limit, so maybe if this is brief, go ahead, please.
Quick question. Ade Adamson from UT Austin. This is for Louise. Unlike, say, in cancer and in cardiovascular disease, there's another party, the parents, to deal with, and they also have something to gain or lose by getting a diagnosis. How is it that you incorporate their peace of mind, say they get by having a diagnosis? Should their feelings be part of the calculus at all, or should it just be about the cost benefit for the patient or the child themselves?
Louise, that's a great question to end on.
That's a great question. I'm going to add to that. I think that there's not only the parents, but I think the teachers also can play quite an important role. And I do, and bear in mind, I'm not a psychologist or a psychiatrist. I can present data that we found, and I didn't look into that. But I do personally feel that, of course, the parents and the teacher, the child's direct environment is important in this. Because if the parents are stressed out, no end all day, and they worry about their child, and they find it difficult to parent their other children maybe, And the same with the teachers. If it's difficult for them to teach a classroom, if they're not supported enough through assistance and financial resources and all that, it makes it a lot harder for the child to thrive, right? So, but yeah, I think I'll probably leave it at that, saying that I'm not a clinician. I think that's for others to determine. That at the top of this should always be the child's well-being and welfare. And I do think that nearly all parents and teachers, adults surrounding a child, will have that on their mind as well.
Great.
That's what they want to achieve.
All right, thank you. So I think that was a wonderful session. I want to thank all of the speakers. Jenna has told me there is nobody online for questions.